the last session, we basically finished up a good strong part of GIT, mesenteric ischemia being the last topic, and then it delves right into practice questions that were pretty debatable questions, like big bulk amounts of people getting the wrong answer. So let's see. This first one wasn't so bad, but you don't want to be that 20%. So it says 45-year-old woman comes to the office due to reflux, nausea, and vomiting for the past 3 weeks. She has daily heartburn, regurgitation, and a sour taste in her mouth. Alright, so right away you already kind of see, where this is kind of going towards. It looks like something is wrong with like the stomach and above, right? So you want to rule out any answer choice that might be after the stomach. She also has severe nocturnal reflux and has been sleeping in a recumbent chair, which makes you start thinking of like possibly GERD. She has had postprandial, non-bloody, non-bilious emesis. Non-bilious stuff is always going to be a big deal because that's when you know that the problem hasn't exactly reached past the duodenum, right? So it's like bile is added after maybe the second or third part of the duodenum, depending on different people, but definitely not in the first part. So this is before that. Non-bilious emesis, initially with solid food, but lately also with liquids. So now that's concerning, because remember how we talked about with the esophagus, whether it's just solid food or solid and liquid, depends on, that tells you what the real problem is. Let me see. Oh, my bad, guys. I was muted here. As I was saying, let me start over. Sorry. The recording got it, but I was just saying that last time we finished up the topics of mesenteric ischemia, and then now we're going to be just wrapping up some of these big questions that I like picking on questions that big number of people got wrong so that we can point it out and not be that 20% in this first question, right? So as I'm reading these questions, what I'm going to do is break down what I'm analyzing as I'm reading it. It's a pretty chilly day in New York today. Even though I'm warm in here, I was just, again, wiping off some snow so that it doesn't all add up. Alright, so first question right here. 45-year-old woman comes to the office due to reflux, nausea, and vomiting for the past 2 weeks. She has daily heartburn, regurgitation, and a sour taste in her mouth, which makes you think that it looks a little like GERD. She also has severe nocturnal reflux and has been sleeping in a recumbent chair. She has had postprandial, non-bloody, non-bilious emesis, initially with solid food, but lately also with liquids. So right there you already know that whatever's wrong has to be before the first part of the duodenum. Bile is added in either the second or third part. It differs in some people, but definitely not in the first part of the duodenum. So wherever her problem is before the stomach for the most part. And then looking at solid food versus liquids, right? So her problem is looking like it's progressive, where initially her problem was just solid food. Solid food won't go down your esophagus if there's some kind of obstruction, but liquids will go. And then now her problem looks like it's solid and liquid over a certain 3 weeks. So that's pretty concerning because liquid won't go down if there isn't a good peristaltic movement. She has not had fevers, diaphoresis, dizziness, syncope, abdominal pain, diarrhea, or constipation. Okay, that's fine. She underwent a laparoscopic Roux-en-Y gastric bypass 4 months ago and has since lost 45 pounds. So I put a picture of it from UWorld. There's different types of gastric bypasses you can get done, but the general scheme of gastric bypass is all going to be the same like this, the way that it is in that picture, especially the one that they're pointing out, the Roux-en-Y. She had that 4 months ago, though, and successfully lost 45 pounds, which is good. That's why she got the bypass. Medical history includes morbid obesity, diabetes, hypertension. She does not take aspirin or NSAIDs and does not smoke, drink, or do drugs. Okay. Temperature's a little high. Blood pressure's fine. Pulse is fine. No orthostatic changes. So these things basically tell you the orthostatic change in the blood pressure part and the fact that she's not, vomiting blood or anything, that there isn't any loss of blood. There's no bleeding issue. Physical exam shows a well-healed surgical scar. There is mild epigastric tenderness without guarding or rebound tenderness. The remainder of the exam reveals no abnormalities. What's the next best step in her management? Right? The typical CK question you would expect. Yeah, thanks for pointing out that the mic was muted. I didn't realize. All right, so let's go. So what would you do now? Looking at the fact that her surgical scar is well healed, but there's a little bit of epigastric tenderness, makes you think that the tenderness she's feeling, the pain she's having, the epigastric pain that she's complaining of here, and her vomiting aren't related to the surgical scar. The surgical scar has healed, her surgery was fine, and successfully helped her lose weight. So now we need to see what the problem is, right? 50% of people chose the correct answer, which was to just do the esophagogastric duodenoscopy and see what's wrong, right? You're going to basically have to go in and check why solid and liquid foods are not passing by. But 20% of people chose gastric emptying scan, and then 20% of people chose trial of a PPI therapy, which is the general thing you do anytime a patient has GERD, right? So let's see what happened with this question. The patient underwent a gastric bypass, which bypasses most of the stomach by creating a small gastric pouch, a gastrojejuno anastomosis, and a jejunal anastomosis. So you can see all of that here, right? They connected the part of the duodenum right here all the way to the jejunum, right? And then this is going to be for anything that is in the stomach. And then this is the dietary nutrients part, where everything she's eating is basically going to go into this gastric pouch and then go straight to, again, the jejunum. This is a way to get people to not really eat too much, and this part, this gastric pouch, cannot expand as much as the normal stomach can. Weight loss results from restricting food consumption because of the smaller gastric pouch and inducing malabsorption, as nutrients can only be absorbed in the common limb, where food meets the pancreatic enzymes. The procedure is associated with several post-operative complications. She likely has stomal stenosis, which you wouldn't really think of, caused by progressive narrowing of the GJ anastomosis that leads to obstruction of gastric pouch outflow. So the reason you would think of it now is because you're seeing it in this question. But the general gist of this is that all her symptoms after having gotten, if she didn't get a bypass, then her symptoms would be a whole different category of things. But it's because of her bypass that you start wondering, now that she has this different anatomy, anything she's eating should just pass here and go perfectly fine into the jejunum and get digested. But it's not, because it must be getting stuck somewhere here, right? Not some kind of GERD problem per se. This complication usually occurs within the first year after surgery, likely due to local tissue ischemia and ulceration. Patients typically have progressive symptoms, including nausea, postprandial vomiting, GERD, and dysphagia, to the point of not tolerating liquids. Diagnosis requires visualization, and that's what you have to think of, right? When you get such a problem, there can be different variations of such patient presentations. Point is that you would have to see what the problem is. So you would do the duodenoscopy. And you would do it from the esophagus, so it's esophagogastroduodenoscopy. You're basically looking through everything of the upper part of the GIT before you get to the colon. Because if you look in the colon, then that would require a colonoscopy, which is from the other side. Patients get this pretty commonly in the real world, because what happens is this surgery doesn't mean that you're just going to lose all your weight. You have to also control what you eat, and some patients, even after getting the surgery, don't control what they eat. Diagnosis will require having to look, and patients sometimes require surgical revision if the balloon dilation fails. Now, the other two answer choices were relevant, but not exactly the correct answer choice for her case scenario. A gastric emptying scan is the test of choice for gastroparesis, which can present with postprandial pain, vomiting, and early satiety similar to her, but recent bypass surgery renders this test inaccurate and raises suspicion for outlet obstruction that must be investigated with an EGD. Right? Her presentation was only occurring because after the surgery there's an obstruction. Marginal ulcers can also occur at the GJ anastomosis, right? So this is with the trial of PPI therapy, and can present symptomatically like stomal stenosis. These ulcers can be treated with PPIs, but their presence should first be confirmed with an EGD. As you see how giving a trial of PPI therapy is something you would eventually do, but it's not the next step in management. It'll be later on, after you have visualized what's actually happening. Right? So 40% of people chose between these two wrong answer choices, and 50% got it right. Very critical thing. This is what makes CK hard. Right? But once you start getting better at having a good clinical suspicion based off of what's happening, you see what you need to do. Right? So when you get such a patient, you're not just going to go ahead and give them any new medications or try any kind of procedure that wouldn't really work on someone who has a gastric bypass, right? So doing a gastric emptying scan won't really work for her. Gastroparesis is something that does occur though. This is a common complication from all kinds of surgeries. All kinds of surgeries can lead to gastroparesis. Gastroparesis can also just occur for no reason whatsoever. Many people have constipation even though their diets must be perfect, right? So it can just happen to anyone. This question was pretty crazy too, because here 60% of people chose the wrong answer choice, which was dumping syndrome. So I explained what dumping syndrome is, right? There was also a table given for that because this actually isn't a topic that's discussed that much in first aid, but it is something you need to be aware of. So this 38-year-old woman comes to the office due to intermittent abdominal bloating and diarrhea for the past 2 months. She has 5 or 6 loose, large volume greasy stools a day. These episodes are often severe after a meal, but there are no specific foods that trigger the symptoms. Okay. So bloating and diarrhea is the real issue here, and it's greasy stools, which means that it's actually coming back, before really mixing with bile that well. She has a history of morbid obesity and lost 66 pounds after undergoing, once again, the same kind of Roux-en-Y gastric bypass surgery 2 years ago. So you see how both of these questions are perfectly here, because the first one was within a year. The second question that we're looking at right now is after a year, so this is 2 years in now. Other medical conditions include hyperlipidemia, hypertension, both of which improved after the bypass surgery. Great. She probably lost weight too. She used to drink alcohol occasionally, but has been abstinent for the past 5 years and doesn't smoke or do drugs. She takes multivitamins, which is essential because remember the DJ ICE mnemonic, right? So there's a DJ ICE mnemonic. Is in for business. So is in for business is supposed to remind you of in for business. So what that tells you is iron, B4, and B12. These are just different. Iron and folate. For is, excuse me, let me fix that real quick. It's for FOR. So in for the F, okay, and business. This mnemonic DJ ICE is in for business is something that one of my professors way back in med school had actually told me about. I haven't really seen it too much, nor have I really ever heard anyone else say it, but this mnemonic stuck to me because it tells you that these are the parts that absorb these different parts, these different vitamins, right? So duodenum for iron, jejunum for folate, and iron for B12. So patients that get a gastric bypass done don't really have full access to all of these parts very well, and food often doesn't get absorbed too well in them either, which of course is because they want to lose weight. So taking multivitamins is good. She has no history of recent travel or exposure to any diarrheal illness. Temperature is fine, blood pressure is fine, pulse is fine. But as they, in this question, they actually didn't say she lost a lot of weight, nor did they give what her BMI was before. But even now, her BMI is very high, 34. And so she's still pretty overweight. But she had a history of morbid obesity, right? So even though they said she's lost 66 pounds, sure, that's great and that's perfect for her and it's helping her, but she's still quite overweight. Abdominal exam shows mild diffuse tenderness to palpation without rebound tenderness. So again, the same thing, right? She has tenderness. Bowel sounds are increased. Stool testing demonstrates increased fecal fat, but is negative for occult blood, so no internal bleeding. Lab results are as follows, and then they show you the CBC and serum chem. In the CBC, they're really pointing out the fact that her leukocytes are 9,000. Other than that, the rest of this isn't so bad. Hemoglobin 11, MCV 106, platelets 275K. Serum chemistry, potassium is very low, right? This is supposed to be between, you want it to be around 4, right? 4 would be a good number, so this is definitely concerning. Bicarb, creatinine is 0.6, that's weird. We look for a creatinine of just 1, straight up, right? And then glucose 110, albumin 4, and ESR 11. ESR is erythrocyte sedimentation rate, which is usually indicative of inflammation, but hers isn't super high. What is the most likely cause of her symptoms? So there's 2 answer choices that almost everyone chose. 60% chose dumping syndrome for a good reason, and we'll get to that. But the correct answer here was just small intestinal bacterial overgrowth. That's all that was wrong with her. Her presentation, she has abdominal bloating, steatorrhea, right, all the greasy stools, and macrocytic anemia, in the sense that her MCV that they pointed out is 106, right? Hemoglobin being 11 is like the beginning of anemia. We generally want hemoglobin to always be around 13. That would be preferential. You can, of course, as you keep practicing questions, you want to start memorizing these numbers so you don't have to check the charts and stuff. But she didn't really come in presenting with fatigue or anything, so you don't immediately think of anemia. But when you look at the labs they're giving you, you really wonder why they're telling it to you. Right, so you see the hemoglobin and MCV, and it should kind of sort of ring a bell for you, and you move on from there. The proximal small intestine normally contains minimal bacterial colonization due to gastric acidity and peristalsis. However, and this is something you learn about gastric bypass procedures result in a blind loop of intestine that allows for excessive bacterial overgrowth. And the acidity isn't going to be that much either, because when food normally enters the stomach and then goes here, all the food faces a lot of acid, and then right here you start releasing bicarb to kind of get rid of that acidity, and everything goes well. But now that's not going to happen after getting a gastric bypass done. And chances are she wasn't really controlling her diet that well. Conditions that alter intestinal motility, like systemic sclerosis, diabetes, or anatomy, like strictures, as well as gastric pancreatic secretions, also predispose patients to small intestinal bacterial overgrowth, SIBO. Patients with SIBO typically develop bloating, flatulence, abdominal discomfort, and watery diarrhea. In severe cases, malabsorption and weight loss are seen. Her steatorrhea was the key thing. Her weight loss here, though, was covered up, right? Because we expect her to have weight loss due to the gastric bypass surgery. So that wasn't very super evident in this question, because her weight loss, you wouldn't attribute it to anything else besides the fact that she got a gastric bypass done. Labs are frequently normal, but may demonstrate nutritional deficiencies and associated macrocytic anemia. Diagnostic tests include carbohydrate breath tests that measure the production of hydrogen by the intestinal flora. Endoscopy with jejunal aspirate and culture showing increased bacterial burden are also used. Management involves a correction of the underlying abnormality, dietary modification, and a short course of empiric antibiotics. So if you get the same question stem again and they ask you a different question of what would you do next to diagnose her, then this question explanation is telling you that to diagnose her, you would just do the carbohydrate breath test. One of the key things to watch out for in this question were that there were no crazy red flag symptoms, right? She didn't have any extremely weird red flag symptoms. To have bloating and diarrhea, anytime there's diarrhea, we usually think it's related to some kind of infection, right? People eat things that they couldn't digest too well, or because they had some kind of infection. She didn't have infection per se, but it was because of bacterial overgrowth. And this is because in a non-gastric bypass individual, you would assume that it must be either they're unable to digest what they're eating, like celiac or lactose intolerance, right? Or that the patient has some kind of infection causing diarrhea. But almost all causes of diarrhea, all those infectious causes of diarrhea, and we looked at some of them, are ones that self-resolve within 2 weeks, right? Some of them went up to like 10 days or whatever, but they all do self-resolve eventually. Her issues have been happening for 2 months, right? So when you have a person with gastric bypass, these are the things you consider, right? In the first question, we considered all the case scenarios where symptoms of GERD were popping up, right? And then we had to do an EGD to check. Here, she doesn't have symptoms of GERD, right? It's the other way, right? So now, in the first patient, food was coming back up, and in this person, food is exiting too quickly, and it's all greasy. So all you have to do is a carbohydrate breath test, and you would see what's wrong with her. Her dietary modification is going to be the biggest thing, right? Just like when we talked about cardiovascular and MIs, and we said that managing an MI, of course, is very intense, but the real course of management comes after you go home. When the patient goes home and decides to not stop eating terrible foods, decides to not exercise, decides to not really maintain their blood sugar levels well, then their MI is just going to lead to another MI, and they're probably going to die. Right, so dietary modification is the biggest deal. Getting a gastric bypass isn't a free pass to losing weight. So what's dumping syndrome, and why does 60% of people pick it? Dumping syndrome is a complication of gastric bypass also. This occurs when high-carb foods are rapidly emptied into the small bowel, leading to osmotically driven fluid shifts and the plasma to the intestine. Right, so again, carbs are delicious and people love that stuff, and after getting a gastric bypass, you definitely have to cut back on it. So it does happen, of course, that people get gastric bypass surgery done and just keep ingesting high amounts of carb. So all that carb isn't really going to have much time to be, digested anywhere. It's going to go all the way straight into the jejunum. And along with carbs, along with sugar, comes all the water. So that's why it's osmotically driven. Although patients have abdominal pain and diarrhea after meals, the fluid shifts result in sympathetic activation, leading to tachycardia, diaphoresis, and flushing. Hypoglycemia may also occur, but she didn't really have that. Her glucose is within normal range. Dumping syndrome is not associated with steatorrhea. or even B12 deficiency. Remember that if someone has steatorrhea and they're having greasy stools, then you needed those greases. Remember from Biochem Nutrition that there were some vitamins that were considered to be fat-soluble vitamins. But if you're not really having any fat that's staying in you and all the fat just comes out in your poop, then those fat-soluble vitamins are also going to come out. And then since the ileum, as we said in our DGI mnemonic, since the ileum is the last part where you actually absorb B12, all of this extra stuff that's being dumped in there and actually being dumped out in feces is going to bring out that B12 too. There won't be any time to really absorb that very well, right? So dumping syndrome is going to have a lot of osmotic watery diarrhea, right? But not exactly steatorrhea. So that's what this table here is telling you about, right? But again, this presentation for dumping syndrome is going to be very different. And of course, the 60% of people that chose it, these people obviously must have looked into dumping syndrome at some point and known what it does and that it is related to a Roux-en-Y gastric bypass, but it doesn't cause steatorrhea. Right? So that's the key thing right there. Here, again, 20% of people chose the wrong answer. So this one was about C. difficile. 59-year-old man comes to the office for a post-operative follow-up. He underwent a partial distal gastrectomy for a perforated peptic ulcer 3 weeks ago. So again, we have a gastrectomy. A part of the stomach has been taken out because of peptic ulcers. He also received an extended course of antibiotics with the last dose given 2 weeks ago. For the last 10 days, he's had intermittent abdominal cramps and diarrhea. Okay, symptoms began 30 minutes after eating and are associated with nausea, weakness, palpitations, lightheadedness, and diaphoresis. So I'm going to stop right here and bring you back to the fact that right here we just saw most people who have osmotically driven fluid shifts from the plasma to the intestine will end up having sympathetic activation, which is going to cause the tachycardia, diaphoresis, and flushing. A very important thing to remember. Clinically, you're going to see this, and we're seeing a pretty similar kind of thing here too. He has no symptoms overnight and no fever or weight loss. Medical history is notable for hypertension. He does smoke a lot, 20-pack year smoking history, but he quit after the recent hospitalization, which of course isn't really going to be that meaningful because the effects still linger on. The surgical wound is healing well, but without erythema or discharge. Cardiopulmonary exam is fine, CBC is fine, so there's no anemia. What is the most appropriate step in management? So here the answer was what we saw here, just dietary modification. 50% of people chose it correctly. That's all this patient needed. This question here is dumping syndrome. So you see this patient has dumping syndrome, a common post-gastrectomy complication due to loss of pyloric sphincter action. Can't be C. difficile because he doesn't have fever or leukocytosis, and the postprandial onset of symptoms overnight is consistent exactly with what we read about dumping syndrome up here, that it occurs within 30 minutes after eating, usually has a fluid shift that causes sympathetic activation, and we saw all of that in this question. So these 3 questions, once again, are put into the book perfectly to orchestrate the course of events that occur related to having a gastrectomy or a gastric bypass or any of these things. Right? Perfect set of questions right there. The next one here, again, 50% chose the correct answer and 40% chose between 2 wrong answers. So what happened here? This is a very elderly patient, 82, is brought to the hospital with 3 days of fever, productive cough, and shortness of breath. He was admitted to the hospital 2 months ago with right lower lobe pneumonia. Okay. His wife reports that he coughs, chokes, and has nasal regurgitation when swallowing liquids or solids. So that's pretty bad, right? Liquids or solids. So something's definitely not working in terms of like peristalsis or some kind of really, really, really bad obstruction. He admits the food gets stuck in his throat when swallowing. He has a history of hypertension, diabetes, ischemic stroke, chronic kidney disease, coronary artery disease, and advanced dementia. So a lot of things have added up in the 82 years of life. Temperature is high, blood pressure is mildly high, pulse is fast, right? Respiratory rate is 20. Neck exam shows midline trachea without a palpable mass. Lung exam shows crackles in the right lower lung field. So that's pretty concerning because that means there's something still wrong in the lungs. Abdomen is soft and non-tender. Chest imaging reveals right lower lobe pneumonia without additional mass lesions. So apparently 2 months ago he had just come in for a right lower lobe pneumonia and he's still having that problem. What is the most appropriate next step in management of his dysphagia? So they don't want you to deal with the pneumonia for this question. They just want to know what you would do about the dysphagia he's having. Dysphagia is a huge problem. If your patient can't eat well, then recovery is really going to be halted down. So 50% of people chose the correct thing. Just do what you would always do for dysphagia problems, the barium swallow. Right? We talked about this when we did esophagus stuff, that almost all different case scenarios led to the same answer choice, do the barium swallow. Let me real quick to the esophageal disease. So this thing here, right? Evaluation of dysphagia. No matter what the problem was, you did a barium swallow at the end of the day, right? And it was only one case scenario where you did an upper endoscopy, and that was the really, really weird case scenario of all kinds of things where you had mechanical obstruction, so only solids aren't going, and then eventually liquids don't go either because the solids aren't going. And then they have a history that doesn't include anything where you would suspect they have some kind of cancer. So now you really need to do an endoscopy to go in and look what's wrong. You have to go in and look, because if they don't have a history of things that could cause esophageal cancer, then what could be happening? Because there's no reason for them to right now have esophageal cancer. So that's what happened in that question. It was the complexity of the wording of the question that threw some people off. The majority of people chose the correct answer. 20% of people chose to do an upper GI endoscopy. That was the other answer choice for where you don't have any suspicion, any reason to really think they have cancer. But again, here in this case scenario, the barium swallow is the best way to analyze this, and we're going to see why. The other 20% of people chose esophageal motility studies, but the motility study would really just have to do with solids and liquids all the time from the beginning. Right, so this is something that, this is a classic CK question where honestly all three answer choices do look convincingly correct. So what's the best answer choice? Just do the barium swallow. Dysphagia can be classified as oropharyngeal or esophageal. And this is the difference that you have to be able to make to be able to pick the correct answer choice. Oropharyngeal dysphagia presents with difficulty initiating a swallow due to inability to properly transfer food from the mouth to the pharynx. Underlying etiologies include many of the things he has, such as stroke, which he had, advanced dementia, which he has, oropharyngeal malignancy, or neuromuscular disorders. Patients with oropharyngeal dysphagia, because his food was just getting stuck in his throat and he really couldn't eat it all. Patients with oropharyngeal dysphagia can also have associated coughing, choking, or nasal regurgitation on swallowing. Other complications can include aspiration pneumonia and weight loss. His history of stroke with coughing and choking on swallowing suggests oropharyngeal dysphagia. Recurrent right lower lobe pneumonia suggests likely aspiration pneumonia. And that was what they were trying to give you in this question. The fact that this is a GIT question, but they keep mentioning pneumonia that already happened 2 months ago and occurred again, and they had this big hint that he had a stroke and he's very, very old and he has dementia, was a giveaway that things are not exactly working too well over here. Things aren't working too well anywhere for him. So things are not working very well in his esophagus and oropharyngeal area. Video fluoroscopic modified barium swallow study is preferred initially in these patients to evaluate swallowing mechanics, degree of dysfunction, and the severity of aspiration. This is the next best step. Then they have the other two answer choices explanation. Esophageal motility studies and upper GI endoscopy are typically used for evaluating esophageal dysphagia, which presents with a sensation of food getting stuck in the esophagus, not the throat, a few seconds after a swallow, but does not cause difficulty initiating swallowing. His findings are more concerning for oropharyngeal dysphagia. So until you get to understand the difference between oropharyngeal versus esophageal dysphagia, all three of these answer choices seem very plausible. In fact, for him, if you don't think of those differences between oropharyngeal versus esophageal, then the best answer choice does look like to just do an upper GI endoscopy, because he has no reason to have had any kind of cancer, so you would have to go in and see what's stopping the food from passing. But it's not that food isn't passing in the esophagus, food is getting stuck right in the mouth, right in the oropharyngeal area, because the dynamics and the mechanics in his throat are just not working too well. Right? So that's the big thing here. It's his throat, not the esophagus per se. So this question did a great job helping you see the difference between those things. And in this question, they added in the aspiration pneumonia aspect of things, which really, if the same question was put in an NBME, they probably wouldn't do that. They would just have this stuff. They would have you with the patient who's having trouble with food getting stuck in his mouth, right? He can't initiate swallow. Food gets stuck as soon as he tries swallowing. What do you do? Right? And they would tell you that he has a history of all these things. Now, what do you do? So you should do the video fluoroscopic modified barium swallow. All right. Last question here. Again, 40% chose the correct answer and 40% chose the wrong answer. So what happened here? A 43-year-old woman is brought to the emergency department with bloody emesis. So that's a red flag symptom, right? You have blood coming out in the vomit. Her medical history is significant for idiopathic cirrhosis. So that's a liver problem. So if we start, everything I underline is generally things I would highlight when I'm taking the test. She was hospitalized 5 months ago for variceal band ligation. On initial evaluation, blood pressure is very low, so she might be in shock. Right? Blood pressure is low, pulse is high. Pulse oximetry is fine. Patient is somnolent and barely arousable to sternal rub. Dried blood is seen around her mouth. The abdomen is distended with a positive fluid shift. 1+ peripheral edema. Hemoglobin is low. Platelet count is also low. And the INT is 1.9. 2 large bore catheters are placed and 2 liters of normal saline are rapidly infused. That would be the next best step for her management. Despite resuscitation with crystalloids, the patient remains minimally responsive, and her blood pressure is still low, pulse is still high. While still in the emergency department, she continues to have repeated episodes of bloody vomiting with clots. A unit-packed red blood cell is prepared for transfusion. What's the best next step in her management? And for her, with her case scenario, it really looks like she's about to die if she keeps vomiting like this, right? So you just intubate the patient. It makes sense to think of it if you were actually in the clinic with such a patient, if you're in the hospital setting and they keep vomiting blood no matter how much blood you're giving them. This looks like a patient that's becoming pretty critical. You intubate, right? You don't order an upper GI endoscopy. Do you really want to, pressure a patient like this into an endoscopy? Probably not. It's not going to go too well. This patient has upper GI bleeding with ongoing hematemesis and altered mental status, mainly because of all the bleeding. She's losing her mind. Given her history of cirrhosis and variceal band ligation, esophageal variceal hemorrhage is the most likely cause. Right? This esophageal variceal hemorrhage was supposed to come to your mind when they told you she has cirrhosis and they did a variceal band ligation because she must have been bleeding somewhere. So now she has esophageal varices, and that's why she's bleeding from her mouth. Right? There aren't that many case scenarios where you could really be bleeding from the mouth. And in such a patient, with all the things given for a clinical scenario, the esophageal varices is what you immediately think of and you intubate. Initial evaluation and management of patients with variceal hemorrhage should focus on maintaining adequate circulation, preventing and treating complications, and stopping the underlying cause of bleeding. 2 large bore catheters have been placed, crystalloid solution has been administered for volume resuscitation, and a packed RBC transfusion, which is indicated even though her hemoglobin is more than 7, because of her hemodynamic instability, it's all being prepared, right? So all the correct things are being done. However, she continued hematemesis with clots and depressed level of consciousness, which are major risks for aspiration, which could quickly exacerbate her tenuous clinical status. She could die. While the patient awaits urgent endoscopic intervention, rapid sequence endotracheal intubation should be performed to prevent airway compromise due to aspiration of blood. Intubation also assists gastroenterologists in performing an upper endoscopy, especially in patients unable to maintain their own airway. Patients with cirrhosis and variceal bleeding should also receive prophylactic antibiotics to prevent spontaneous bacterial peritonitis, something that occurs. This is actually, SBP is actually a step 1 topic. And a somatostatin analog to reduce the variceal hemorrhage because somatostatin stabilizes everything. And it'll also stop her from making more gastrin and all kinds of other stuff. All in all, improving her hemostasis, right? Stop her from bleeding. The other reason, the reason the people chose the other answer choice is because this is something you'll eventually do, but after the endotracheal intubation. Right? This is the clinical presentation of what happens in CK. This is what you're going to keep seeing in CK, where you're going to have a list of answer choices of all the things you would actually do to the patient, but just not in the order it's given. Right? So you have to pick the correct order of things. That's all CK is really trying to get you to do. Upper GI endoscopy with variceal ligation or sclerotherapy is critical to stop this patient's variceal hemorrhage. However, in patients with significantly altered mental status and persistent vomiting of blood, it should be performed after the patient's airway is protected. Right? If you were to do that without the intubation, then doing the upper GI endoscopy at that point can actually, before you even do it or while you do it, she could end up taking blood into the wrong place, right? The airway, blood into the airway, into the lungs, and then she could die very quickly. So these questions do a great job not just teaching you what's happening and filling you in on some information, but also showing you presentations that are all very unique. Right? If you were a GI doctor specialist, these are things you would see throughout the day, right, in the emergency department. And after that, we move on to our disorders of the large bowel. So this includes a bunch of things. So we have our diverticular disease, all the kinds of things that are related to diverticulosis, large bowel obstruction, which are mainly going to be obstructions in the colon. Right? This is different from the small bowel obstructions, which are in the small intestine and sometimes in the proximal duodenum and in the stomach area. A bunch of practice questions we'll get to later on. And then, yeah, colorectal cancer, huge topic. Same stuff from step 1, nothing brand new here. Ischemic colitis, and then pilonidal disease, which is a pretty new thing compared to step 1. This wasn't really discussed so much in step 1, although pilonidal disease was something in the step 1 NBMEs. So let's take a look at all this. So diverticular disease. So what is diverticular disease? So here in this image right here, we're seeing diverticulitis. Each one of these things, these outpouchings, they're called diverticuli, right? So this is one diverticulum. It takes the entire thing, all 3 layers. All the layers are there, right? And when you do a colonoscopy, this is how it's going to present. You're just going to see holes. Holes are outpouchings. When I did my GIT rotation, I learned that, the doctor asked me a very interesting question to which I didn't know the answer. So hopefully your doctor will ask you too at some point. Maybe your attending will ask, and you will know. He asked, why do these outpouchings occur where they occur? Like, why right there and not like right here or here, right? Or everywhere? Why in these specific places? And that's because those are the places where this blood vessel must be entering. Okay, that's what makes those places vulnerable to an outpouching. Right, so essentially, you see this blood vessel that's coming here, it must be entering through this area into the inner area to supply this, innermost layer of the colon. It's perforating, right? The blood vessel must be perforating through in that one vicinity, and that vicinity was weak enough to have a outpouching occur. Right? It's a very critical thing. Very interesting question he had asked that I truly didn't really know, like why. Okay, so now you know. Now the problem with this is a little bag where, of course, things can just sit in, right? That's really not good, right? So that's pretty bad. And then, of course, even in there, as things sit in there, you can see there's a micro perforation that occurred, and you don't want perforation anywhere in the GIT, right, for the thing to rip, because then these contents are going to come out into your body, right, in the inner part of your body outside of the GIT, which of course predisposes you to infection, peritonitis, and all kinds of other problems. Coming back to the step 1 book, let me just find where we talk about this stuff. Diverticula. Yeah, right here. So right here you can see in step 1, right, you have the diverticulum, diverticulosis, and diverticulitis, which usually in step 1 questions had all 3 answer choices there, and you have to truly know the difference between them to pick one over the other. A diverticulum is exactly that, and we saw it, right? It usually occurs in the sigmoid colon because there's a lot of pressure there, and it could be either a true diverticulum or a false diverticulum. So the true diverticulum, as we saw, is the one where all 3 layers pouch out. Right, so this is going to be all gut wall layers, such as even in the mechodiverticulum. A pseudo-diverticulum is where only the mucosa and submucosa outpouch. Occurs especially where the vasa recta perforate the muscularis externa. So you see, this was the answer to the question that my doctor had asked me. But I didn't know, even though I definitely read it here. But it just didn't stick to me, which is something I tell people all the time, that when you're reading chapters, right, you always want to, if you're sitting there, you're studying the diverticula of the GI tract, and this is the topic you're looking at right now, you read it all, and then you put the book away, and you try to revise all of that to yourself without the book in front of you, so that anything you miss, you can come back and look at it again and be like, oh yeah, I forgot about that part, and now, hopefully, it'll stick to you a lot better, right? So most diverticula are acquired and are actually termed false diverticula. In fact, as far as step 1 is concerned, and as far as step in general is concerned, the only true diverticulum you'll ever really have are the mechodiverticula, right? The one we're looking at right here, in this image, they've done a good job showing you that the mucosa and the submucosa came out, but the muscular layer is just fine. Right? The muscular layer is just fine. And that's the thing here. When you have all gut wall layers versus only having the mucosa and the submucosa. This is the one that usually happens. Not all gut layers are going to come out. The muscular layer is going to be just fine. Right? And that's what you're seeing. This meatier dark pink part is the muscular layer. And your tinea coli that you can see on actual examination of the colon, on raw examination of the colon, is actually part of the muscle. Right? That's the muscle there. So very important thing to keep in mind. Little technical things. But again, diverticular or false diverticular. All diverticular disease is false diverticular, except either they mention that the muscular layer is out, or if it's a mechodiverticulum, which is actually the muscular layer as well. So M for mecho, M for muscular. Diverticulosis is when you have multiples. Right? So one diverticulum is one. When you have too many of them, like in this image here, that's going to be diverticulosis. When you have multiples, and they're commonly in the sigmoid area. Right? Very common in people over age 60. And why does it occur? Is because of increased intraluminal pressure and weaknesses in the colonic wall, specifically in the areas where the vasorecta are perforating that muscularis externa layer. This is associated with fibers that are low in this is associated with diets that are low in fiber, and it's usually going to be seen in patients who have a history of constipation. Right? A lot of constipation increases pressure in the colon, and then of course that pressure causes to push through that one area where the vasorecta is perforating, and you end up getting a bunch of diverticula. All of that can, of course, lead to what we saw earlier, ripping through, perforation, and you can get bleeding. And diverticulitis is an itis. This is a type of inflammation where you have inflammation of the diverticula with wall thickening. Classically causes lower left quadrant pain. So lower right quadrant pain is usually the appendicitis, and that's going to have rebound tenderness. Lower left quadrant pain is due to the fact that, if you look at this image right here, if you were to put the human body, then you see this is the lower left quadrant, right? Whereas your appendix would be more over here somewhere, right? So that's the right lower quadrant, right? And of course, this is something that you just treat with antibiotics, and there's not much else to really do there. You're going to see leukocytosis because of the fact that this is an inflammation. They have the list of complications here, which of course can present in questions. If your patient with diverticula has pneumoturia, then that means that there must be a fistula. What is this fistula? So this fistula is because you see how this outpouching is sticking out? It can stick out and connect to the bladder. And then if it connects to the bladder, then you're going to have a connection between the bladder and the colon, which of course can lead to urine, and that's not supposed to be in the colon area. You don't need that. So pneumoturia, that's what they're talking about here. Colovesicle. Colon and vesicle is a pouch of water, really. So colovesicle and vesicle, anything in medicine, is usually related to the bladder. So this is something that you would see in the question. It could cause obstruction, of course, because these outpouchings are like possibly going to impede movement of things. And of course perforation, as we just saw in our image over there. So that perforation is what leads to peritonitis, which is a really problematic presentation, and of course you have to deal with that pretty intensely. So we're going to see that soon. Right? So that covers like the general bulk of everything you really need to know when you have a patient with diverticula. We talked about the differences between these 3D words, and then the risk factors, we talked about that. In this image here, right, so they wrote here diverticulosis is the most common cause of acute lower GI bleeding in patients over age 40. So this is something that you have to have a clinical suspicion of when you have a patient over age 40 with GI bleeding all of a sudden. In this image here is acute diverticulitis. So how would you cast that? If this red circle wasn't there, right, then how would you actually see it? Because the red circle helps, but without the red circle, what are you actually looking at here? But then it becomes very hard, as you could tell. Right? Without the red circle, it becomes very hard to the untrained eye to really see anything. I mean, of course, the liver looks fine, the gallbladder looks fine, but then what? Right? So move back. Coronal reconstruction from grab my pencil. Coronal reconstruction from a contrast-enhanced CT demonstrates sigmoid diverticula with pre-sigmoid inflammatory fat stranding. The area of abnormality is circled in red. The liver, stomach, gallbladder, and then the urinary bladder are all labeled. But this circled area, you wouldn't really have the mental capacity to see if such an image was given. I'll be honest, like if they give you this picture on a test, you won't really catch what's in this red circle. Your eyes won't zoom in here. If anything, your eyes are really going to focus on the white areas and be like, what the hell is happening in those white areas? Right? And why do those white areas have the same color as the stomach? But then you won't really think of this area here, which is actually showing you acute diverticulitis. So, this image is here to do one thing and one thing only, which is if you have a question where they give you such an image and the liver looks fine, the stomach looks fine, the gallbladder looks fine, the urinary bladder looks fine, there isn't any connection between any part and the urinary bladder, then you start thinking of diverticulitis and you move on. Right? It's not because you're actually going to see this. This can occur here, it can really be pretty much anywhere. The reason they have it circled there is because, as we said in the Step 1 book, it occurs in the left lower quadrant. Right? So that's why they're circling the left lower quadrant. Most diverticular will be in the left lower quadrant because that's where the sigmoid is. So your eyes should look in the left lower quadrant, but of course, even after looking there, you won't really see anything because eyes still really don't see anything if that circle isn't there. Diverticulosis is often asymptomatic until patients present with sudden intermittent painless bleeding, which can cause symptoms of anemia when bleeding is severe. Right? This is associated, as we said earlier, with chronic constipation, which increases intraluminal pressure. Diverticulitis, the inflammatory thing, is going to have the left lower quadrant pain, fever, nausea, vomiting, perforation is a serious complication, which can lead to peritonitis and shock. Right? So these things are pretty dangerous, and given the fact that this occurs in people over age 40, and more commonly as you get older, if a person over age 60 has this, they could theoretically die if they don't come in for treatment, or if you don't catch this and treat it. Clinical history is important. CBC will show leukocytosis and anemia. Most accurate test is just to do a colonoscopy. So thank God, right? Because this is what we always think of anyway when someone has bleeding through the rectum. You just do the colonoscopy. When you have a patient who's over age 50 and they have anemia, especially if it's a male, the first thing you think of is do a colonoscopy because you need to see if they have occult bleeding somewhere. And doing the colonoscopy will show you the diverticular disease, right? You have to go in and look, and you would see all of this. Right? You would see the outpouchings from the inside. So from the inside, you're not going to see that, but what you will see is this. Because you're in here, your camera is in this lumen. Always remember that. So you see these bags, right? They shouldn't be there. In acute diverticulitis, CT scan is best for diagnosis, and it may reveal inflammation or abscess. So this image here is supposed to be showing you abscess. The reason you can theoretically see abscess, especially the more you train your eye, is because if you look at all of these different parts in here, right, they're all sharing a color. Everything is sharing a color except this part, right? This is all dark gray, the rest is all white, and then you have this right here, which is a different shade of gray. Right? And then right there, the fact that now my mouse is on the left lower quadrant, really you start thinking of diverticular stuff, and then if they have fever, nausea, and vomiting, diverticulitis, and you move on. All right. Treatment. So if it's an uncomplicated diverticulosis, you just do routine follow-up and tell them to take a high-fiber diet. There are all kinds of things out in the market, like psyllium husk. Psyllium husk is amazing. Psyllium husk is basically a powder that you can mix into water. Usually it has a flavoring to it, like orange soda or something, and you can just drink that. So even if you don't have a high-fiber diet, because you're drinking that fiber drink once a day, everything will be fine. And it also gets rid of the constipation. So that's something that you could prescribe, right? Psyllium husk is one of the things that's actually mentioned in the Step 1 book in the pharmacology section for all the laxative things you could take. Psyllium is not exactly per se, it is a laxative, but not the typical type of laxative like Dulcolax and all these other medications that you could take. This just encourages movement of feces just because of the high fiber, which is an osmotic laxative, right? It's going to pull water into the colon and push things out. If they have diverticular bleeding, then of course bleeding usually stops spontaneously. That is something that can happen. It can stop also. But if there is bleeding, you transfuse and hydrate as needed. That's all you really have to do, right? If bleeding does not stop, though, then hemostasis by colonoscopy, angiography with embolization, or surgery will be indicated, right? Because if you do things to stop the bleeding and you can't get it to stop and you're transfusing the person, then you don't want to keep transfusing the person. There's no point in transfusing someone that still has internal bleeding. It's just going to go to waste. So you have to do the colonoscopy to see what's happening. You have to go in and look to see why are you still bleeding. Diverticulitis, you treat with bowel rest. Right? If you have diverticulitis, you have an inflammation, you don't want to keep eating. Nasogastric tube placement, if severe, and broad-spectrum antibiotics like metronidazole or fluoroquinolone or a third-generation cephalosporin. And then colonoscopy after the initial stage. So you can imagine that for a diverticulitis question, you're going to have colonoscopy as an answer choice, but that's not the next best step in management. The next best step in management is first to do the bowel rest. If that's already been done, then you could consider colonoscopy. But you have to get this initial stage done, right? The bowel rest, the antibiotics, and then colonoscopy. Treatment could involve hospitalization if there is evidence of peritonitis or systemic signs of infection, because this is really bad, right? The peritonitis and shock is not something that's going to get better if they go home. And if there's a perforation, you have to do immediate surgical resection of the diseased bowel. And this is called a Hartmann procedure, right, with a temporary colostomy. So a colostomy is basically going to be their new way of pooping for the momentary time. But if you see with this perforation area, where the perioleum is coming out, you're going to have to get rid of that. You're going to have to just cut this portion out. And this portion has to be rid. So you can't just cut that portion out. It's a tube, right? Your colon is a long tube, so you cut that entire little area out where this is happening. And so you would take a cross section just like it is in the image, a cross section, but before the perforated area and after the perforated area, and remove that. That's your Hartmann procedure right there. You can look up more pictures of that to see how that is done. There might be even videos on YouTube. Diverticulitis, the inflammatory guy, is the one that's the most high yield of all of these, right? Because this is the one that can lead to many, many complications and issues, and it's very questionable, right? A very good way to ask all kinds of questions for this topic. And this diverticulitis, as we just saw, because of the inflammatory aspect of things, you already have a diverticula, now it's inflamed, it can connect with other things, and we talked about that. The fistulas leading to pneumoturia, fecal urea, or fecal discharge from the vagina. Right, so these are all things that should not be happening in a normal individual. Next topic is large bowel obstruction. So right here in this x-ray right here, you're seeing an anteroposterior x-ray from a barium enema in a patient with a large bowel obstruction, revealing a massively dilated sigmoid colon and a bird's beak appearance of the barium column of the cytovolvulus. So you see how this bird's beak appearance is the same thing we saw in the esophagus too when we did the barium swallow for this same obstructive problem in achalasia. Right? And achalasia was also an obstructive problem where you didn't have food passing anymore, and then when you filled it up with the barium, all of that barium filled up all the little bit of space that was left, and now you can see there must be an obstruction right here. Things are not passing. Right? This barium enema was given from the bottom up, right? So it was rectally given, and it didn't go all the way up to the rest of the colon. So now you know where the obstruction is, and then you can proceed with whatever surgical procedure is necessary at that point. So that's your large bowel obstruction. This is to never be confused with a small bowel obstruction. You can't be confusing the two with each other in questions, and we're going to see how to do that, right? So this, there's a table later on we're going to see it describes the features that distinguish SBO from LBO. But that distinguishing shouldn't really be so difficult, right? So they have a very nice table here. Let's look at this image here. So this is a complicated small bowel obstruction with perforation, and we saw a little bit of this before. Right, so this is a different image now. It's very nice. Previously, we looked at SBO with comparison to ileus, and that video is already up. Now we're looking at it with comparison to LBO. And, on the left is the blank one. On the right side, they've actually, shown you that when you have these flat lines, that's when you know you have air fluid levels. That's going to be an answer choice to pick too. Because even if you didn't really think of SBO in the question, if they just want to know what you would expect, or if they ask you what you see in the x-ray, you pick air fluid levels because you have these flat lines due to the air in there. Right? And then free air under the diaphragm as well. Right? This is a complicated small bowel obstruction with perforation that's causing air to leak out everywhere. Right? This is not supposed to happen. So this patient in this question had abdominal pain, fever, and peritonitis. You could tell because of the abdominal rigidity. And in this question, the patient had a subdiaphragmatic free air on lateral decubitus x-ray. So when they tell you how you would evaluate this, you get the patient to be on a lateral decubitus position, and then you start seeing it when you do the x-ray, indicating a perforated viscus. Right? Given his history of hemicolectomy, the most likely cause of perforation is postoperative adhesions leading to bowel obstruction. So I didn't put the question there, but the explanation is letting you know what happened in the question, and then you can figure out the rest of that from right there. Now, clinical suspicion of GI perforation can be confirmed by demonstration of intraperitoneal free air on x-ray. Right, on imaging. Free air on x-ray and clinical signs of peritonitis should prompt emergent surgical exploration to prevent deterioration and death. Perforation is a big problem, and diverticulitis is one of the things that can cause it. Diverticula can all perforate if the patient isn't managed. So take your time going through this table, but generally speaking, you should see that there are clear, big differences between the two. Right? And one of the biggest differences are going to be the obstipation part, that if you have a large bowel obstruction, literally nothing is going to come out. No air or feces, right? And we saw that connection in comparison earlier as well. So your job is to make sure you can differentiate between SBO, ileus, and LBO. There should be very clear differences between all three. Okay. Next thing, colorectal cancer. So colorectal cancer, back in step 1, was one of the most high-yield topics when it came to the GIT. Right, so let's jump over to, right after polyps, we have Lynch syndrome and CRC, right, where you can see all these gross images showing you all kinds of things that are happening. Iron deficiency anemia in males and postmenopausal females raises suspicion for colorectal cancer, at which point you always order the colonoscopy if they haven't had one done pretty recently, within a year or two. Screen low-risk patients starting at age 50. Alternatives include doing a flexible sigmoidoscopy, FOBT, FIT, and CT colonography. But those are all other alternatives. Really depend on why you would really need it. If the patient, already can just get a colonoscopy done. Some patients are just very adamant about not really getting a colonoscopy done because, of course, it's not fun to get it done. It could be embarrassing, etc., etc. But at the end of the day, nothing is worse than just dying because of something stupid like this, right? So you want to get it checked out. Patients with a first-degree relative who has colon cancer should be screened earlier, right? 10 years prior to their relative's presentation. So if their relative had a presentation of colon cancer at age 42, then you start screening their relative at 32, right? Patients with IBD have a distinct screening protocol that, of course, Step 1 book didn't really go into, right? But if you have irritable bowel disease, right, then there's a different protocol for them, and we'll get to that. Let me see. I can't remember if I mentioned it here. No, I didn't mention it here. Okay, but that's a whole different thing that I'll come back to. Carcinoembryonic antigen, this can be an answer choice as well, is a good tumor marker. The only reason you would check for this is to see if there was recurrence. But you don't screen using this, right? You don't check for carcinoembryonic antigen, find CEA, and then be like, oh my god, you must have colorectal cancer. No. You screen for it with just colonoscopy. Okay, and then you use CEA to see if there was recurrence or more that you might not have initially found. Now, there was a big difference between rectosigmoid ascending and descending, right? The rectosigmoid area is the number one area where you get colorectal cancer. And then there's different reasons why you could have colorectal cancer in the ascending versus descending areas, and their presentation is going to be unique. There is clear difference between the two. If you have it in the ascending colon, right, so that's the right-sided, the right-sided ascending colon cancers tend to grow as large, bulky masses that protrude into the colonic lumen due to the relatively large caliber of the ascending colon. They are more likely to bleed and cause iron deficiency anemia. The bleeding is usually occult and detected by fecal blood testing. Right, so that's your ascending. It's going to be a big exophytic mass that can lead to iron deficiency anemia and weight loss. The descending one is on the left. The left-sided ones, either rectosigmoid or descending, tend to be smaller. They often infiltrate the wall of the colon, encircling it and narrowing the lumen. Therefore, they are more likely to cause obstruction because the lumen is narrowed now, like this. Right? You see how big the lumen was here, and then you see how thin it is here now. So, of course, things are just going to pile up over here. Therefore, they are more likely to cause obstruction, and patients generally have altered bowel habits, abdominal distension, and vomiting because if everything backs up, everything comes back out from the mouth. The liver and lung are common sites of metastases of any kind of colorectal cancer. Right, so the right side bleeds and the left side obstructs. Very important thing to remember. Coming back to RCK books, they describe the same stuff here. The right side of the lesion is often bulky, ulcerating masses, patients complain of weight loss, diarrhea, anorexia, feeling weak. Obstruction is very rare on the right side. The right side just causes ulcerating masses, which cause you to bleed. The left side ones are going to be the obstructing masses that cause an apple core lesion. So you can see the apple core lesion in this image on the top right. Right, this image here is showing you an apple core lesion, and what they're talking about when they call it an apple core lesion is because it looks like an apple core, like that. And so that's what they call an apple core lesion. Colon carcinoma, the encircling carcinoma appears as an apple core filling defect in the descending colon on barium enema. Because the barium is the white stuff, so it's filling all of that area, it's filling all of this area, but in here the lumen must be really thin. So the lumen is really thin because of the obstruction that's occurring. And this is a left-sided thing on the descending part of the colon. The right side gets just bleeding to occur because of the big masses that form. Right? But the right side doesn't cause obstruction per se. Rectal lesions usually present with bright red blood per rectum, and you'll see it. You won't have to do a fecal occult blood test at that point. Often with tenesmus and or rectal pain, rectal cancer must be ruled out in all patients with rectal bleeding. However, a negative FOBT has insufficient sensitivity to exclude the possibility of cancer. Right, so this doesn't rule it out. Fecal occult blood testing, you can do it, but it's not like sensitive enough. The best thing is just the colonoscopy, where you can actually see if there's a problem. Right. Here, this is an abdominal CT showing multiple liver lesions. So you have multiple lesions in the liver rather than just one in one specific area, which suggests metastatic disease to the liver rather than a primary liver cancer. A primary liver cancer would be just in one bulky area, like all of this, right? Just there, or all of this, any lobe area, and it would just be full of cancer. Colorectal cancer is the most common source of liver metastases since blood from the colon moves through the portal circulation directly to the liver. Colonoscopy is the most appropriate next diagnostic step to localize and diagnose where in the colon that cancer is occurring. Right. Moving on, most accurate test, colonoscopy. We've all got that down from step 1 already. Evaluate them for metastases. So you do a chest X-ray, you do the liver function test, and you do an abdominal and pelvic CT to check everywhere to see if there's any metastasis at all. Staging is based on the depth of the tumor penetration into the bowel wall and the presence of lymph node involvement and distant metastases. Once you've seen all of that, you can stage the cancer and figure out how you're going to treat it. The best initial treatment is just to do surgical resection of the tumor. For sure, that makes sense. You find the tumor and you get rid of it. Then you do adjuvant chemotherapy, especially in cases with positive lymph nodes, right? If there was actually involvement of lymph nodes, and you just follow with serial CEA levels to detect recurrence. You could do colonoscopy more frequently to make sure everything's okay, and keep checking every other part to see if there's any new metastases that didn't occur when you initially checked. Right? Maybe after checking everything, 2 to 3 weeks later, something metastasized somewhere or started showing up. Now you have to keep checking. You have to keep screening that patient. So you have your screening recommendations, which you get questions on. We talked about this first part, right? If there's no past medical or family history of colorectal cancer, then you start screening at age 50. Annual digital rectal exam and home fecal occult blood testing is one option, colonoscopy every 10 years, and sigmoidoscopy every 5 years. If you have a first-degree relative, then you do colonoscopy every 5 years, starting at 40 years of age, or colonoscopy every 5 years, starting 10 years before the age of whatever age that patient, that relative, first-degree relative, was first diagnosed at. If the patient has ulcerative colitis is better than Crohn's disease, but ulcerative colitis is an inflammation of the colon, which can lead to colon cancer. Inflammation can always lead to cancer. Colonoscopy every 1 to 2 years now, right? You're doing it much more frequently. The best case scenario for a patient with ulcerative colitis would be to do it every year, starting 8 to 10 years after diagnosis, right? Because after diagnosis, things are just going to keep getting worse, even if they're treating it, and then eventually they could develop colon cancer. If the person has HNPCC, hereditary non-polyposis colon cancer, this one is interesting. This is a person with a type of colon cancer that has no polyps. That's in the name, NP. So if we come back to here, right? That's your Lynch syndrome, previously known as HNPCC. Now we just call it Lynch syndrome. There's the 3-2-1 rule. Lynch syndrome can be diagnosed with the 3-2-1 rule, in which 3 relatives with Lynch-associated cancers across 2 generations, and one of those who was diagnosed before age 50. That classically occurs in this question right here. It's perfect. 38-year-old man, he's pretty young, is evaluated for bloody stools, weight loss, and anemia. So that sounds like a ascending type of colorectal cancer. His past medical history is unremarkable, and he doesn't take any medications. He uses tobacco, drinks socially, so far everything looks great. The patient's father, however, died of colon cancer at a very young age. And his younger sister has endometrial cancer. Examination shows a right-sided abdominal tenderness without guarding. Stool has occult blood, and colonoscopy shows a right-sided ulcerative lesion, as we predicted, because of his presentation. Right? Weight loss and anemia. Not a left-sided one, where you would have the apple core lesion, and food is backing up because the lumen is so small now. No polyps are noted, which is a giveaway for Lynch syndrome. Biopsy of the mass reveals adenocarcinoma and a mutation in which of the genes would be the thing associated. So everything about this question was great until you read the final thing, which is the actual question, and then you're like, what the fuck? Because if you didn't remember the mutation related, which is something very step 1 type of thing to do, then you can't answer the question. So there's a bunch of genes that are associated, right? Here the correct answer would have been any one of these things: MSH2, MLH1, MSH6, PMS2, right? But the most important ones are MLH. Okay, so that's something that you need to make sure you know about Lynch syndrome. That's this case scenario here. And then FAP, familial adenomatous polyposis. This requires sigmoidoscopy every year, starting 12 years of age. Very, very young, because it's a familial thing. Right, so these are the patients that require colonoscopies and sigmoidoscopies at a super young age. Imagine having to do sigmoidoscopies starting at age 12. That just sucks, right? But it's an unfortunate thing that has to be done. We see that, so this is one of the topics that we just read about. But where's the FAP? Oh, okay. So in the step 1 book, they break down colonic polyps much better than the CK book. And you want to make sure you go back and kind of just have a general understanding of the different types of polyps you can get, right? These are your generally non-neoplastic ones, and then the malignant ones can either be glandular, adenomatous, or serrated. And then even in here, in the adenomatous type, there's multiple types in that, right? You could either have one that's got the tubular histology or villus histology, right? So they show you that in images B and C. Image B is a bunch of tubes. Imagine this is a bunch of tubes you're looking at with a bird's eye view. So you can put your finger in each of the tubes. That's tubular. Villus doesn't have the tubular. It's long villi. These are very long, finger-like projections. Right? Villus is villainous. That has the highest malignancy. And you can get something that's mixed, tubulovillus, which is an intermediate malignancy, but it's still malignant, and that's pretty problematic. But polyposis syndromes, this is the one we're looking at right now, and then there's 1 and 2 different variations of it. Right? You could have someone who has FAP alone. This is an autosomal dominant mutation of the tumor suppressor APC gene, APC for adenomatous polyposis cancer, on chromosome 5. So since this is a tumor suppressor, both tumor suppressors have to die to not be able to suppress tumor anymore, and then you get infinite tumors starting right after puberty. Pancolonic in the whole colon. Always involves the rectum. So you always do sigmoidoscopy. You don't have to do the whole colonoscopy. You don't need to check the entire colon. You could just check the sigmoid area, and you would see polyps at a very young age, and that's a giveaway that you need to start doing something. Right? Prophylactic colectomy, or else 100% progression to CRC. This is why you have to keep checking at a very, very young age for these patients with FAP. The other 2 variations are Gardner and Turcotte, which you can just remember off the names. Gardner has osseous and soft tissue tumors as well, such as osteomas of the skull or mandible. So you could get a question that starts off with that, a musculoskeletal question, where maybe a 10-year-old patient shows up with some kind of soft tissue tumor in the skull or mandible, and then you have to start thinking of checking for FAP. Ask about family history, right? The name Gardner makes me think of guarding your face, right? Because you're going to have tumors in the face, retinal pigment epithelium hypertrophy, and impact of supernumerary teeth. So you really look like someone hit your face with a bat, right? So that's kind of what's happening here. All messed up in the face. So you guard your face. Turcotte just reminds you of turban, which perfectly works, right? This is going to be related to a malignant CNS tumor out of nowhere. So someone with a malignant CNS tumor and a family history of FAP or Lynch, either one, adenomatous or no non-polyposis, either one of those. So again, very intense, very complex, a lot of things happening, but not complicated, right? It's not complicated. It's not like the various physiological things occurring in the heart. That was pretty complicated. Here it's complex because there's a lot of different angles, a lot of things happening, but it's all pretty straightforward once you start looking at it. It's just the volume of things happening is a lot, right? The last things here are just Peutz-Jeghers syndrome and juvenile polyposis syndrome. Juvenile polyposis syndrome is even younger, autosomal dominant syndrome in kids under age 5, with numerous hamartomatous polyps in the colon, stomach, and small bowel. This is also associated with the risk of CRC. So you can already see that this can be confusing because FAP and JPS are both occurring in kids. But the problem is the type of polyp. Right? In here, you have adenomatous polyps, which is a malignant thing. But in juvenile polyposis syndrome, you're having hamartomatous polyps, right? Which is not malignant. Right? It's just solitary lesions with no risk of transformation. You just have growths of normal colonic tissue. That's what a hamartoma usually is. It's a cancer that's just like the rest of the tissue around that cancer. But Peutz Jeghers is a big problem. Once you have Peutz Jeghers, you start seeing all kinds of things, and you really got to just look into it. Right? You got to start doing whatever you can to save the child as early as possible. So Peutz Jeghers here, this one is going to have hamartomas as well, but they're going to have other symptoms. They're going to have this stuff, right? Hyperpigmented macules on the mouth, lips, hands, genitalia, associated with increased risk of breast and GI cancer, and is just completely problematic. These all suck. And so things to be grateful for. We don't have any of those issues, then we're doing great. And that's really it for the colorectal cancer stuff. But it's a lot. It's a lot, so you want to make sure you keep revising it, keep going into it. Ischemic colitis is pretty simple. It's just colitis, just like ulcerative colitis, but there's no ulcerations here. This is ischemic, you're bleeding. Insufficient blood supply to the colon that results in ischemia and potentially necrosis, and then that part can die. Most commonly affects the left colon, particularly the watershed area at the splenic flexure. Usually occurs in the setting of atherosclerosis. So let's go back and revise that little bit of anatomy real quick from GIT. Let's see. Okay, so right here we have all our blood vessels. These are images that you can find easily from Amboss, right? And I just put them together to connect them like that. So the cannon point and the watershed area basically all right here. You imagine that if you have one area that's supplied by multiple arteries, that it'll do great, but it's actually the opposite of that. So what you're seeing here is the SMA and the IMA, right? These guys have the ability to give each other collateral blood supply, such that if by any means you might have an atherosclerotic lesion here that cuts off blood supply there, then things coming from your inferior mesenteric artery can go around and give blood to the other side, right? They can supply each other. You can see the connections here, right? It's not like they're not connected to each other. The SMA and IMA are connected to each other, and they can help each other. However, that doesn't mean they want to help each other, or that they're significantly supplied to be able to help each other. So what often happens is that areas where you're sharing blood supply actually get the least amount of blood. So where are you sharing blood supply? Well, it's this artery right here. You see this artery that's coming from the SMA, this artery right here. Right? It's coming from the SMA, coming from the middle colic artery, and then it goes over to the other side to supply this area. Right? But the blood that came in this artery that I marked with 2 X's, the blood that actually came in there was from the SMA. Right? And then it went over here in this direction to supply this area. Blood would also come from the IMA, inferior mesenteric artery, go through the left colic artery, right? So left colic artery, and come up in this direction as well. So you see how blood is coming from both directions in that one area that's marked with the yellow color? That area is special for multiple reasons. First of all, it's called the cannon point. Why? Because proximal to the cannon point, parasympathetic innervation is provided by the vagus nerve. After that, it's all pelvic splenic nerve. So the nerve supply also changes. And it's also special because this is sort of your splenic flexure area, which is where your arteries are sharing blood supply. So you get a little bit of blood from both sides. So if you get a little bit of blood from area 1 and a little bit of blood from area 2, as soon as area 1 no longer brings blood because you have this atherosclerotic lesion here, you start losing blood there, and that can lead to ischemic colitis. The same exact case scenario plays a role if the atherosclerotic lesion was here instead. Then of course you would get lesser blood from area 2 and more blood from 1, but it wouldn't be enough. Okay, so these are case scenarios of atherosclerosis. Most people who get atherosclerosis in one of these 2 arteries usually have atherosclerosis in one of the more prominent arteries, right? The areas that it's more likely to occur, like the carotid and the coronary arteries. So presents with crampy lower abdominal pain, followed by bloody diarrhea after meals or exertion or in the heat. Very similar to coronary atherosclerosis, where you have pain, right, the angina, right after exertion, after using the organ. So same thing here. They get pain after using the organ, after eating or just exertion in the heat, which lowers the amount of water in the colon. If there's any fever or peritoneal sign, that just indicates bowel necrosis, that area must be dying now because it didn't get enough blood, right? And that's going to suck. The Cannon point is a very high yield topic because you always get questions on it. So, vagus nerve comes down all of this, right? Your vagus nerve is the longest cranial nerve. It comes down all of this, and it gives some good amount of parasympathetic innervation to these areas as well. But then the rest of this is all coming from your pelvic splanchnic nerve. So you have to make sure you know that stuff, right? Very important topic because all that topic gets tested with your portal system and all kinds of other stuff. And they just throw that in. It was mainly a step 1 topic, but it could pop up. It could pop up in CK as well. Anything from step 1 can pop up on CK. You're just hoping it won't. All right. Most accurate test, of course, is doing angiography, just like you would for the heart. Colonoscopy may show pale mucosa with petechial bleeding, and it will be an answer choice, but you don't really pick that. You don't need to. The initial test is just to do a CT scan with contrast, and you'll see the thickened bowel wall and atherosclerosis, and you're done. You figured it out. All right. Last thing was your pilonidal disease, which is a painful, fluctuant mass that develops in the anal area of obese individuals with sedentary lifestyles. So this is going to be an obese person whose job might be a truck driver. And he presents to the clinic and he has this big, fluctuant anal mass. This can present with purulent, bloody, or mucoid discharge, and all you have to do is surgical drainage. So it's not that bad of a case scenario. It's okay. You can deal with it. You can actually resolve this pretty well. Hopefully he starts working out and has a less sedentary lifestyle after this. But if he can't do anything about it, then it will probably happen again. Now, this question on the right is about ischemic colitis. So the answer was just ischemic colitis. Very straightforward. 56-year-old woman comes to the office for evaluation of chronic diarrhea. She began experiencing daily watery bowel movements many months ago and tried eliminating dairy products, but the diarrhea got worse because she must have thought it was lactose intolerance, but it wasn't. Lately, she has been having 5 to 6 bowel movements daily and occasionally at night. She has had no melena, hematochezia, fever, abdominal pain, nausea, vomiting, or weight loss, but does have fecal urgency. So those symptoms tell you, or the lack of those symptoms tell you, that if you see an answer choice that is supposed to cause one of those things, you don't pick that answer choice. Right? So if there's an answer choice that's supposed to cause vomiting, supposed to cause weight loss, supposed to cause abdominal pain, you just lock out those answer choices. Don't think too hard about it. That was a very important list of things that she doesn't have. Right? She doesn't have melena, bleeding, any of that stuff. Home medication just includes hydrochlorothiazide and naproxen, which is an NSAID. She drinks a glass of wine with dinner daily, but does not smoke. Vitals are fine. Abdomen is non-distended, soft, and non-tender, with no organomegaly. Bowel sounds are normal active. Stool testing for a occult blood test is negative, no bleeding. Colonoscopy reveals a normal appearing colon. So this question is teaching you that when a patient presents in this way, you would do the colonoscopy, right? Which makes sense because she's got some issue and we can't figure out what's happening. Right? You would do a stool testing, but again, stool testing just for the FOBT and because it's easy to do for the most part. Random colonic biopsies demonstrate mononuclear cell infiltration of the lamina propria and a thickened subepithelial collagen band. What is the most likely diagnosis? So this question was very good at showing you a very different way of seeing what you would imagine to see for, after reading the book, because the book doesn't really present the case scenario the way it is in this question. So that's why I put it here. She has microscopic colitis, MC, an immune-mediated colitis characterized by watery, non-bloody diarrhea. Her colitis isn't due to atherosclerosis. That's why I put this question here, because you can get colitis from different ways. So the book version was the one where a patient is presenting with crampy lower abdominal pain, followed by bloody diarrhea after eating, right? And then you would have to do a CT scan to find the atherosclerosis. But our patient didn't have that. Our patient didn't present with any blood, actually. Right? She doesn't have any blood. She just has watery bowel movements and chronic diarrhea. That's it. So what's up? Microscopic colitis is a secretory diarrhea, watery, and unlike osmotic diarrhea, may actually occur during periods of fasting and even at night. Other symptoms can include fecal urgency, incontinence, abdominal pain, fatigue, and weight loss. Blood and stool studies are usually unremarkable and perfectly normal. The diagnosis is confirmed with colonoscopy and a biopsy, where you would see the things they pointed out: mononuclear cell infiltration and a thickened subepithelial collagen band because of the because of the inflammation. Where was I? Although the colon appears grossly normal, biopsy the mucosa reveals mononuclear inflammatory infiltrate within the lamina propria. The disease is further subdivided into two types, either the collagenous type or the lymphocytic one. Right? Collagenous colitis with a thickened subepithelial collagen band-like in this patient, or lymphocytic colitis with high levels of intraepithelial lymphocytes. Either way, you're going to see white blood cells because it's autoimmune. Microscopic colitis is likely due to an abnormal response to various GI and external agents. Certain medications have been associated, and she was taking naproxen, which is an NSAID, one of those, right? Many people take PPIs. People with depression are on SSRIs. Older women are disproportionately affected, and those with other autoimmune conditions are at increased risk. Once you have one autoimmune condition, you get more. Women are more prone to autoimmune conditions. So very interesting question. Completely different from what's given here, because although it is a type of colitis, it's not very similar, right? Ischemic colitis is like the angina kind of thing that you would get with the heart related to atherosclerosis. Same thing happening in the colon now, and we already saw it can occur in your small bowel as well. And now here we're seeing a autoimmune version, which is microscopic colitis, right? Completely different presentations between ischemic and microscopic colitis. All right, so this is a really good, bulky topic right now, and you want to make sure you revise all this to get the little differences between SBO, LBO, and ileus. And then next time we'll pick up from looking at these questions together and moving on into GI bleed and IBD, hernias, and we'll be able to wrap this up probably on Friday with the rest of the things related to the liver and pancreas. All right, so thanks a lot for joining, guys. I'll see you guys again later on. Have a good night.